Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm talking this morning with Dr. Eleanor Glass, a family physician in the Cincinnati area who's developed a direct primary care practice along with a colleague that really offers, I think, a very innovative approach to care for patients. I'm not going to let her tell that story. Dr. Glass, it's good to be talking with you.
Thanks, Larry. Glad to be here.
So can you tell us a little bit about yourself, how you came to medicine, where you went to medical school and residency, and then how you began this direct primary care practice?
Sure. So I am, for the most part, from here in Cincinnati. I went to college in St. Louis, and then lived in Vermont, lived abroad for a little bit, but came back from medical school here in Cincinnati and did my residency training here as well. I come from a family that is from a lot of different places, which has kind of influenced my career quite a bit, but for the most part have been here in Cincinnati and have really developed a practice that I think allows me to feel like the real community doctor that I was looking forward to. Another part of my training, while I was in residency, I spent some time out in Arizona doing some acupuncture training, which has also become a big part of my career.
Great. So why don't you tell folks about the name of your practice and who you're practicing with and how it got started?
Great. So after I finished residency, I joined the faculty here at the University of Cincinnati Department of Family and Community Medicine. My initial position was teaching in the residency office. That means that I was seeing patients in a private office, but it was a teaching office. That meant that I often had residents and medical students with me, but as part of a private practice, I felt a lot of the same pressures that many primary care doctors do when they are working for a hospital-owned practice. I also had some teaching time, and I also had some time serving as a medical acupuncturist in the cancer center here. And about 3 years in, I was really pretty quickly developing some of the signs of burnout and seeing it develop quickly in many of my colleagues. A teaching doctor who I had known kind of peripherally, Amy Meckley, who is now my partner, came to me and told me about this model about direct primary care. And it took us about a year of discussions. Amy had already been doing research many, many months ahead of time. But in July of 2017, we opened Integrative Family Care, which is a direct primary care practice. We are here in Cincinnati in the urban core, and we serve patients who have come from any kind of financial background. We have people who have no insurance. We have people who have high deductible plans. We call them the underinsured. We have people with great insurance. We have people on Medicare and Medicaid, and we charge them a low monthly fee directly, and that includes all of their primary care. I think, Larry, what kind of probably is the most interesting point was what was that transition like from kind of leaving the system and going into direct primary care? And for me, that was a really it was a little bit of a no-brainer, but interestingly, my parents are both academic physicians, and I had thought that I would always stay in academia, and I really thought that, in this job, I won't really need to think about the finances. Somebody else manages the business. I just get to spend time focusing on my patients and taking care of them. But it really became pretty clear pretty quickly that if you don't understand the finances of medicine, then you can't take really good care of your patients. Because I had people coming in telling me they were paying hundreds of dollars for each visit with me, or that a simple test that I ordered cost $280, and I had no idea, and I was ordering one every 3 months when actually current guidelines say I could just do it once a year. Without understanding the finances, I couldn't really take precise care of my patients. And discovering a new financial model for primary care, direct primary care, is really what allowed me the freedom to take more control over how I take care of my patients.
That's great. So you mentioned the name of your practice, Integrative Family Care. What is integrative medicine to you, and how does it play out in your direct primary care practice?
Yeah, so interestingly, I do a lot of integrative medicine, but my partner Amy, she does a lot with the American Board of Lifestyle Medicine. She's not formally integrative medicine trained. I'm not really formally integrative medicine trained. I've done extra rotations, I've done extra acupuncture training, and I've done a lot of teaching in the field, but did not do a fellowship. But that's okay. Integrative medicine does not need to be a specialty field. It does not need to be a practitioner who orders only expensive tests and lots of supplements to me, integrative medicine is just really good primary care. It means that I understand the mind, body, and spirit of my patients, that I can answer questions about nutrition and exercise and mental health and have the time to do so. And that's what's so important to me. And that's really what I felt was lacking in primary care practice when I was working for a corporate healthcare system, was the time in order to delve into those topics with my patients. I don't think integrative care really needs to require so much specialty training. It does require some specific skills, but I think all primary care doctors could do that given the time and the model to be able to spend that time with their patients. So for me, I am an acupuncturist, but I would love for nobody to need acupuncture. I, know a lot about supplements, but I would love for nobody to need supplements. I don't recommend a lot of treatments. Mostly we counsel our patients on lifestyle interventions. How are they doing nutritionally? How are they doing movement-wise? What are their relationships like with their family? How can we make sure that we're empowering them to be in their best health in all of those spaces, so that they're less likely to have disease develop.
Great. So could you tell us what's it like for a new patient coming to your practice? What's your standard new patient, how much time you spend in that first encounter, and then what's likely to happen thereafter? There's an hour booked on my schedule, but the patient only sees 50 minutes, and I point that out because it's important, because direct primary care is better for the patients, but it also must be better for the primary care doctor. We have to have time in the day to finish notes, to finish charting, to respond to people's phone calls. A big part of why I believe in the direct primary care movement is because I believe it empowers primary care doctors to feel responsible for their career and how they take care of patients again. But yeah, so the patients are booked for 50 minutes, and typically at the intro session, I always tell them, hey, this is going to be kind of a data download. I want to learn everything about you so that I can put it into my medical record, and because I can take better care of you if I understand your history. And typically something that's really important that I do is that I sit at a table with the patient and I turn my computer towards them so they can see what I'm putting in the computer. I think that shows them that time on the computer is a necessary part of medicine, but it's an active tool for me to take better care of them. And we go through all their family history, medical history. I ask them about diet and nutrition and substances and preventative care. I think the difference that I'm noticing in this practice than before is that I have a little bit more time to ask those questions, and their answers may not be complete the first day, but showing them that I want to know about that shows them that that's important to their health. And I think that's the biggest difference that people see. In my office, also, patients have to take a lot of responsibility. So one of the core tenets of direct primary care is financial sustainability. I can't keep an office open if I hire somebody to do a lot of jobs. So patients have to do their own vital sign monitoring. They check their blood pressure with an automatic blood pressure cuff that has been shown to actually be more accurate than our physician manual blood pressures. They take their own pulse, they take their own height and weight, and then they bring that to me and show me their numbers, and we can talk about those numbers and help engage them in what those numbers mean. Fascinating. So could you share a story about a patient or a family that you believe has benefited from this approach to care?
Sure. Yeah. I oftentimes when I am asked that question in various environments, I oftentimes always end up thinking about the patient I saw the day before, which is, not always the most effective, but sometimes it is. I think the difference that I see across the board with all my patients is that I just have I have time to think about what is needed for the patient in front of me. It's not that I didn't care when I worked for corporate healthcare. It's that the system didn't encourage me to spend more time responding to the needs of the person in front of me. I just had to see people so quickly. But this week I was on the phone with the daughter of a patient who something just didn't make sense. He was having worsening pain and worsening depression. He's an elderly man. He's in his 90s. And I kind of couldn't wrap my head around why he wasn't responding to appropriate meds, or was the depression before the pain? Was the pain before the depression? He also has some cognitive decline, probably some early Alzheimer's, and what was related here. And I had this instinct say, like, I need to go see him in his home. I need to figure this out and look at the problem. And so I said, let me come out to the house. Let's do a home visit, because something is just not adding up. I'm not figuring this out. It's not making sense to me. And so I went and did a home visit, and I think it was so helpful to me as a provider. I think the family was delighted, but it was so helpful to me to understand, that he actually, I was a little hesitant about using higher pain meds because I was worried about polypharmacy, but I was able to see that he and his wife have a very organized system, and they are taking their medicine very, very accurately, and that helped empower me to say, okay, I think we can treat this a little bit more carefully or a little bit more aggressively, because I hear you that your pain is what's causing you to be depressed, not the opposite. And then I was able to coordinate that visit at the same time. He has a palliative care doctor who's helping manage his pain here towards the later years of his life, and we were able to coordinate that visit, and so that I know, that palliative care specialist and I are on the same page, and he will probably take over prescribing and managing some of these problems, but for him to know that the primary care doctor knows what's going on and is involved and engaged if he needs me, I think that was just a positive experience for all of us.
Let me just comment. When I talk to people who are trying to get the best care for their mom or their dad as their mom or dad is approaching end of life, quite often I hear stories of the fragmented care, the difficulty navigating the system, and the sense that people have that the docs don't care enough to invest time and energy. And what I'm hearing from you is direct primary care gives you the freedom to be that kind of family physician, to be really there for your patients, whether it's in the office or in the home. You can take the time and pull the pieces together. It
does, and I want to enunciate, Larry, that it's not always about having more time, because we will get busier. Our practice is still growing. I'm not going to be able to do home visits on every patient all the time. What really to me was the important moment is when I was having this conversation with the daughter, and I was feeling this kind of either frustration building up in me or I just don't understand this. And I was able to have that moment of clarity of, what this needs a home visit, and it needs a coordinated home visit. And schedule allowing, I was able to do that. And that clarity of being able to say, I can figure this out. I can see the missing piece here. That to me is what was unique about the direct primary care experience. Because think about it, that moment required so much coordination. The daughter had to trust me. The daughter had to have my phone number to be able to get a hold of me directly. I had to have a palliative care team that I had done the consult for, so I was able to communicate with them directly about what the patient needed. The patient and his wife are actually both my patients. As a family doctor, I was able to see that this situation, affects both of them and their health, and all that coordination and just having a moment of clarity of, okay, I can see a way through this. That was the delightful moment for me as a doctor. Being able to do the home visit, I'm actually hoping that one home visit will save me time later, because now I have a member of a palliative care team who's empowered to move forward with our treatment plan. So I absolutely, I think increased time helps, but I don't want people to think that it's only having increased time. It's also being able to respond to the needs of the patient directly, and having those moments of clarity that really helps us.
So what strikes me from a problem-solving point of view is that you had the mental space to be aware of that that concern that was building within you, as opposed to having to race off to the next patient and perhaps lose that in the busyness of the day. Right,
and we could have struggled through these questions for months and months without that, and I certainly have done that with patients before. And I know I can. I tend to talk to patients a lot about mindfulness and meditation, and I really feel that in my own practice. When I'm more mindful, I can take better care of people. And I think I was struggling with that question when I was working in, for a hospital system. Why is this not? Why am I getting burned out so early? And this really has shown me how much that space helps. I think it's important to point out that although we are very affordable and a lot of people use us who don't have insurance or who have inadequate insurance, I want this to become more and more affordable. One of my goals is not to spend so much time with people that I can only take care of, a low number of people. I want to be so efficient so efficient in this space that I can take care of somebody who can pay for it and somebody who can't, all for the same amount of money. One membership pays for a person who can't afford it, because I think we can do it. When the physician controls the costs in the office, primary care can be so affordable that I think we can spread this to a lot of people until we have a system of health care that is equitable and available to all.
I'm with you on that one. I'm wondering if you could comment on one other area, chronic pain. So especially as a family doc who thinks about mindfulness and thinks about use of acupuncture and perhaps some other modalities, could you comment on your approach to people with chronic pain? Is this the kind of patient that you're able to care for in a direct primary care through the direct primary care business model?
Yeah, I definitely can. Lots of people, most people have some sort of pain, either a little low back pain or something, and trying to help that pain not develop into more severe pain is important. I think it has to be a multimodal approach. I give a lecture to the medical students every year on integrative approaches to back pain, and one of the most important things I tell them is that you have to have really good diagnostic skills. Sometimes you can't just lump something into a category of musculoskeletal pain. Well, what muscle? Is it piriformis? Is it one of the erector spinae muscles? Which muscle? And are there specific exercises that you could do to help relieve that person's pain? And then I also try to help them to know the data that we have data that shows that exercise plus massage performs better for mild low back pain than any single pill that we prescribe. Knowing that data can help empower the patient to really engage in some of those modalities. Back pain takes work. It is not a passive problem. It's an active problem that requires active engagement from the patient. The question down the road from what you're asking is probably related to the prescribing of opiates, and we do not prescribe as much as we try to engage the patient in management of their symptoms. Opiates should not and cannot be used as frequently as they have been recently in medicine, but when I have a patient, especially at the end of life, I've actually seen opiates be a lifesaver. Pain management is a developing crisis in the third world where they don't have access to drugs. I have seen appropriate use of medications really be a life changer for some in the elderly population, but it has to be done so carefully and so cautiously because of the risks and the side effects. So yes, having the time to manage them and the mindfulness to manage them carefully is very, very important.
Great, thank you for that. So any final comments for those who might be on the bubble thinking, should I stay in my corporate practice or should I look into the direct primary care model? Any final comments for those folks?
No, I think for me, what people don't talk as much about, which they need to, is where are you in life and what's your availability. I was doing this at a time in life when I didn't have kids' school tuitions to pay for, when I don't have I have a very affordable mortgage. You really have to look at your financial picture because it's pretty scary not having an income for a little while. We were very lucky. We grew quickly and we're able to kind of turn the corner from the red to the black within about 6 months, but it takes a lot of resiliency to do this, and running a practice is not always easy, but it is so much fun and it is more engaging, and every decision we make is surrounding the question, how can we best engage our patient population and take great care of people? The questions are never around the health of a corporation or decisions that come down from on high. It's much more engaging. I love it. I take great pride in what I do, and I don't think every family doctor is saying that these days in their current positions. And I'm proud to be able to teach that to my medical students and residents, and have been really delighted so far.
Dr. Glass, thanks so much for talking with us, and it's very exciting to watch how your practice is succeeding in your approach to care. I mean, I think this is what people in America really want. They want a family doctor who can deliver care the way you're delivering care. So thank you for what you're doing.
Thanks, Larry, and thanks for all your support.